Sometimes when you have inflammation on a nerve or a disc, the actual proper method of treatment is not treat that area at all, but treat distally until the inflammation is relieved, and then you can work on it safely without any risk or harm. So I'll do a basic assessment of the glenohumeral joint and see how it's functioning. And this one has all the movement in it that we would expect. So now I'll move to the other side. And I don't know if you can see on the camera here, but from my vantage point, I can see that this shoulder is a good inch higher pronated forward than the left. Now she has the same tendency on the left side, although not as sharp. So one of our goals posturally here to correct this, which is not all due to the injury, some of this was here congenitally. This is her body and her seated posture of her upper body, which is part of the reason why she's vulnerable to injury here, aside from the fact that a coat rack fell on her shoulder. But I don't only want to treat the injury, but I also want to treat the posture in order to get a truly better result. Not only to treat the injury, but also the underlying conditions which create the injury, like the pronated shoulders, which eventually down the line will make her stronger and healthier in the upper body and prevent this kind of injury from happening again. So on this side we see there's a lot more inflammation. I can tell this by not only her pain level, but the thickness and the elasticity in the tissue, and also the sensitivity of the pressure points. We here find that on C1 and C2, slightly subluxation to the left, and around the scalenes, there is a lot of tension where they have become adhered to the transverse processes. So I will gently relieve them, careful not to overstimulate that area because it's close to the nerve and the nerve is still slightly inflamed, I can tell by how sensitive she is to the pressure there. One of my objectives here is to release the pec minor and also the levator scapula, which are in spasm still, and I know that from the last treatment when I worked on her. Although now they have improved by at least 40%, but still they are contracted and in spasm. So, and actually,
generation, there can't be only 4 people in this country doing it. It's ridiculous.
Okay, right. Okay, so now I will work on the upper traps and the levator scapula and the splenius capitis and anterior scalenes, which are very important for releasing the lateral aspect of the transverse processes of C1, 2, 3, and 4. One has to be very careful working around these areas that they do not overstimulate, because you can very easily bruise an inflamed or entrapped nerve. So sensitivity is the key into dosage, so you know how far you can push the point without overstimulating it. Right here, between C2 and C3, I find the inflamed nerve, which Liz can tell you is very painful, even though I'm applying less than a pound of pressure. So it's very important, areas like that, not to overstimulate them. Just a little bit of stimulation is all that's necessary. And then you'll go distally from the area to relieve the pressure from the thoracic outlet, which here again is in spasm. And I can tell by the reaction of the muscle tissue under my hand and how it jumps back when I push on it. So I never want to force. I want to use just as much pressure as the muscle and the nerve can tolerate at this time until the inflammation goes down, and then I'll be able to work on the area with deep pressure safely without risking injuring the nerve. Now, because this injury has been here now for 1.5 years, it has had time to create lots of adhesions between the muscle fibers and the tendons. So this then, over time, becomes more of a problem than the original injury, and also prevents the nerve from recovering, because these muscles, like the pec major and minor, which have gone into spasm around the thoracic outlet, now create constant pressure, re-injuring the neck. Now I will work on the lats and the teres major and minor. I make sure that I put the arm in a position that allows me to do this, and also that is anatomically correct, lining up with her spine, so that when I do work on the muscle that I am targeting, I am also aware of the proper alignment and posture of that joint. I don't want to just allow it to work in a bad position. I want to actually put it in a correct position, and then there, in that position, in that anatomically correct position, is where I will try to release it.